had the pleasure of listening to Dr. Vipul Gupta. Very interesting and very informative. Unfortunately, what happens when we have these 3-4 days RSSDI meetings, there are hundreds of topics obviously on one topic, that is diabetes. So there is going to be some kind of a duplication and also repetition. It's only the delegates who have to bear with us, but I will try to see that it doesn't happen. I also maybe rush to the slides. We know this. We stand number 2. We are not yet number 1. I hope we will not. Of course, our friend Dr. Bansi and the team, all of us want to make this India diabetes free. Let's hope that we can do it. And just see that 50% had poor diabetes control, according to one of the studies. And as measured by HbA1c. That was mentioned by Dr. Bansi also today. But do you know how many people get HbA1c in India? It's less than 10%. So I don't know how. So that means the uncontrolled diabetes could be much more than what is mentioned here. Because sometimes the slides can be very misleading. So don't go by even my own slides unless I am clarifying or you are using your own wisdom. Of course, more than 50% of have complications. So, just like any other developing country, India is experiencing socio-economic progress. Urbanization is happening all over. A lot of rural areas are getting converted into semi-urban or urban. So many studies across India have demonstrated high incidence of diabetes. I don't need to tell all of you. Not only in the urban population, but also in these urbanized rural areas. So it's likely to happen. It's likely to escalate. So because of the considerable disparity in the availability and affordability of diabetes, it's huge. We have a diverse population. We have the poorest of the ones, we have the richest ones. So the management of diabetes depends on who you are. Whether you are urban rich or urban poor, you are rural poor, it's the worst because you have no access, literally. I know Dr. Gupta has already mentioned about it. So lifestyle modification is an effective tool for primary prevention and also for managing diabetes. But I find it is one of the most misused words, is lifestyle modification. We even say LSM. So we are sometimes lazy to say lifestyle modification, but it's never happening. So we need to spend a lot of time on that. In fact, I start feeling now that next year, during my presidency at RSSD, I would request everybody to change this LSM, put some other word, so that could be more effective. Maybe change the habits or even the attitude of the patients and doctors. Then only we can. So we have a lot of social barriers, which even the previous speaker told us, different cultural background, social, and a lot of stigmas that we have. Young women don't want to say that they have diabetes. Type 1 diabetes, as you know, when they get married, many times even my own patients did not even reveal that they have diabetes, and they undergo a lot of torture. Subsequently, the marriages break and so many things happen. But this is a reality that India faces. We have on the other side, there are type 1 diabetics who are on pumps and everything. We really very happily look at them, listen to them, but they are not even 1 in 1,000. In some of the recent meetings where one of the celebrities who is a type 1 diabetic has been telling us, that's fine to listen, but how can that be related to a poor type 1 diabetic who can't afford to buy insulin? We know that the cost of diabetes treatment is very high, and just see if it is not taken care, almost 35% of the cost goes towards hospitalization, spending on the other things. This is one of the interesting slides that has come out of the European study, which I have hired from Dr. Mohan and Anjana. We are going to talk about it. I will talk about the Indian version on this. So what is important is every diabetic is different. All type 2 diabetics are not the same. So there are some simple clinical measures doctors can take, maybe 1 or 2 minutes, to identify clinically what type of diabetics am I dealing with. Can I do something to this patient? So one is individualizing. The second is just looking at simple things like how old is the patient before diagnosis, how is the body weight, in other words, BMI. BMI is sometimes is valid, but it's also fashionable. Sometimes we don't even do BMIs. Many of the doctors do not have height charts. Forget about. So Waist circumference is also useful. HbA1c, if it is done. Serum triglycerides and HDL cholesterol are also important to classify the type of diabetes that you are going to deal with. So I'm coming to one aspect of study, one of done by Dr. Mohan and Anjana, on which we are going to discuss how diabetes in India varies. This is one of the slides that you all know how Indian diabetics are different. The center is, a lot of them have beta cell dysfunction. We are young at onset, we have more complications, we are more prone for coronary artery disease, and of course we have family history, and most of us have become sedentary. This is one slide some of you might have seen before Dr. Mohan's presentation, where these are the 4 types of phenotype that we are predominantly finding in Indian population. What it actually means is, see, 26% of them have severe insulin deficiency diabetes. Mind you, this is type 2 diabetes. And about 26% have obesity or overweight, typical type 2 diabetes, what we talk in the West. But then there is a 12% of the people who have combined insulin resistance as well as deficiency. So together, if you see, about 40% of them have insulin deficiency in our type 2 diabetes. It's a phenomenal figure. But then you're looking at the cross-section of the people, not just the urban obese people. You're looking at middle class people, you're looking at rural people, young people who are underweight also sometimes, lean diabetic, what we call. And of course, about 36% of them have mild age-related diabetes. So that is also important for you to understand that diabetes can come at any age. Even some people ask you, will I become diabetic because I already crossed 70? Typically, I say, these days we have been seeing diabetes even after 8, first time detected. Even during COVID times, you might have seen. So they need to be dealt with. So lean diabetes in comparison to obese people, they are younger at onset, and many of them might require insulin. And it's slightly more common amongst the males. And unfortunately, these thin, young type 2 diabetics, males, so being males, they have the higher incidence of abuse, whether it is smoking or alcohol. So some of the features of diabetes in India, we know them again, which has been mentioned. Apart from the phenotypes, we have illiteracy, we have poverty, we have different kinds of belief systems. And another most important thing is dual disease burden of this country. We have NCDs as well as we have infectious diseases which are quite prevalent in certain areas. Imagine if type 2 diabetes happens to a poor urban Indian. He's in an unsanitary situation, is in a crowded place, living in a small area, so highly prone for respiratory infections, diabetic food, tuberculosis is more common, and tuberculosis and diabetes together can be really bad situation. But these are some of the harsh realities that we Indians face. I mean, some of us practicing in urban areas, catering to upper middle class may not know this, but this is as organization, we always talk about the junk food, the Western junk food like burgers, pizzas, which the young urban people eat. But do you know what other rest of the Indians are eating? They are eating junk food which is even worse than the burgers and pizzas. You may wonder why. And also see this. This is eaten by the poor people in the urban areas. Street food. Our Indian street food is worse than Western junk food. If you see this, all those small packets which have got these fried kara and other things, a lot of trans fat is used in Indian foods, especially in the street food, whether it is biryani, samosa or dosas, they use a lot of trans fat. Trans fat is much more dangerous, and if you classify fats into good, bad, ugly, this is the ugly fat, which can increase the lipids, and probably one of the reasons for increase in coronary artery disease amongst Indians, amongst the poor Indians, among the young fellows. So what do you do about it? Dr. Gupta was telling the government has to take action. Do we ban trans fat as it's happening in many countries? But the government is actually planning to grow palm oil trees because you produce more. We are actually importing a lot of palm oil from Malaysia, which is finally converted into trans fat, which is used in all kinds of foods, whether they are cookies or pastries or processed foods like biscuits, which we feed children. And of course, the street food, as I told you. So physicians have a great role to play because they are important to prevent and early detect. But you have limited resources, you have an illiterate patients. So you need to think differently. And can we practice the evidence-based medicine which West teaches us? Maybe not every time. Even as RSSDI guidelines, which we tried to make, I think we need to evolve further. I've been telling my colleagues, maybe we need to look at special situations where we have written limited resources. Even the Americans are talking about it, managing diabetes at a limited resources, because they too have a lot of homeless people, poor people who have no access to health care. Can you believe it? So what are the relevant factors to the Indian context, which I have mentioned? High prevalence of pre-diabetes is also there, because a lot of them are potentially diabetic. Diabetes comes earlier, we know that. There is a large urban-rural divide. Cost of the treatment is a big issue for us, management. And people are becoming sedentary, and poverty literacy is a big problem, which I have already mentioned. And another problem is adherence and compliance to anti-diabetic treatment. I mean, one of the diabetic patients walks into your clinic, you try to tell him so many things, want to put him on one of the latest drugs which could be expensive. So don't blame the patient if he doesn't come back to you. He might go anywhere. We don't know. He might go across the street to an unqualified practitioner, or even might go to a sadhu or somebody who could give him some powder, something. So we need to spend some time to the patients and tell them genuinely, this is a lifelong disease, we need to something, you need to change your habits so that you can control the disease properly. So health education is very important. Explaining the importance and control of disease, which has been very extensively dealt by the previous speaker. Frequent monitoring blood sugar is important in many situations. People don't do. During COVID time, you might have seen, even my own patients have turned up after 12 months or 18 months coming with high sugars. And also it's very important to identify and treat associated conditions. Simple thing like hypertension. Hypertension is even more dangerous than uncontrolled diabetes. Being a diabetic practitioner, don't ignore hypertension just because you are qualified to treat diabetics. So it's important for you. You want to reduce the complications, so you need to look at hypertension. Please check the blood pressure at every visit. Give them an appropriate antihypertensive drug. Lipids are also very important. The diet plays a big role, and statins if required. You don't need to give statin to everybody, but you need to give them when it is required. And also, why not we have some simple data of our own so that we understand. We have actually devised one or two small data sheets, like just take anthropometry and demography of the patient, and you understand your own patients. And also, probably we are going to generate huge data, India-based data, in the coming year. So what should be our approach? We know it. Try to detect early. Don't ignore the young people. Nowadays, you see the parents bringing their young grown-up son or daughter and finds diabetic, and you can see the parents being so sad to see their own son or daughter becoming diabetic. So somebody who has got a family history, who is overweight, sedentary, around 30, start screening them for diabetes. And one-time checking is not important. He could be normal, but he could become diabetic after 6 months or 1 year. Frequent checking is important. You warn them if they are obese. Ask them to keep checking often, especially if they have family history. So it's also important when we are dealing with adult diabetic patients. Some of us forget to ask them, do you have daughters or sons who are grown up? Are they overweight? So ask them to check the blood glucose of their own offsprings and the family, rest of the family. These are simple things. Sometimes we tend not to highlight in some of these meetings. So that's one of the reasons why I took up this topic. I know it's a virtual meeting. There are also others who are attending. This is about type 1 diabetic. This is one of my own diabetic kids, poor kid who has died. Illiterate parents. The parents have not one diabetic child. You keep on telling them about the importance of managing diabetes, taking insulin 4 times, checking blood glucose. But these parents have another 3, 4 children. They have to look after them. They have to look after themselves. So it's a huge social issue. And we need to work quite a lot on it. And I know there are a lot of people who are trying to help our type 1 diabetic children, especially those who belong to poor backgrounds. So we need to do something. It's not so easy to translate science into your clinical practice when you are practicing in India, and especially if you are conscientious to manage your patient, to individualize the patient, to see, don't lose your own patient. You will lose the patient if you try to tell too many things on the right first visit or write too many drugs. I see prescriptions where straight away lot of drugs, anti-diabetic drugs are written, expensive drugs are written. Just see whether the patient can buy it or not. So these are very important things. And of course, we are saying we want to make India a diabetes care capital of the world. I don't want to sound pessimistic. I want to all of us to realize the hard facts of diabetes in India. And then we need to do something about it. RSSDA is actually embarking on so many things. And thanks to Dr. Bansi and the team, and I'm one of the team members. And I'll be taking over RSSDI. And then we want to do more for the people of this country. We also want our doctors to become more involved in the prevention, in early detection, and in proper management. You read the guidelines, don't forget, even the American guidelines say individualize the management. How do you individualize? Age of onset, social status, obese or not. Then you start managing the patients with the drugs, with the standard management. Start with the simple. Don't forget about, I have started developing a dislike to use the word lifestyle management. So let me say, let us change the habits of the people. Habits of the people. So I was just thinking, we talk about BMI, basal metabolic index. So I was saying, why not use BMI some other way? That is, habits, change the habits of the Indians. I'm just forgetting how we can use the BMI otherwise. So let us change the habits of all our Indians. So as Dr. Vipul said, let's start with ourselves. So and maintain it with our family, neighbors, everybody. So take care of yourselves and all the best to all our friends who are also virtually there. And thank you very much for giving me this opportunity. Thank